Good morning, everyone, and thank you so much for joining us for NAMI Maryland's 40th Annual Conference. My name is Alexis Brown with NAMI Maryland. I will be your moderator for this session. This workshop session is Schizophrenia and Gluten, New Target and Precision Medicine, presented by Deanna Kelly from the Maryland Psychiatric Research Center. You can read more about our amazing presenter, including her full bio and the digital conference program, on the official conference website. In this workshop, currently treatments for schizophrenia remain inadequate and precision medicine is often not used. For better identification and treatment, we need to move toward better precision medicine and identify treatments that best meet the needs of individual patients. Education can help relay gaps in care and summarize new data emerging on potential future treatment targets. This presentation will talk about a subgroup of people with schizophrenia that have higher inflammation and antibodies to gluten, a protein in wheat, barley, and rye. I will discuss possible treatments options in this group of people. If this is not the workshop you meant to attend, please click the back button on your browser or click on the Sessions button on the left-hand side of your screen to return to the full list of workshops we have available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them to the Q&A on the right-hand side of your screen. We will be reviewing questions as they come in, and if something is not clear or needs to be expanded, we will ask our presenter after their presentation has concluded. We are pleased to offer closed captioning for this year's conference. Captioning is only available for attendees using a desktop. To enable captioning, please click on the CC icon below the display of our presenters at the bottom of your screen. Once you click the icon, the video displays will become smaller and you will see the captions being generated underneath. If you have any comments, concerns, or technical issues, please post them to our chat and our technical assistant will address them accordingly. I'd now like to welcome our presenter for today's workshop, Deanna Kelly. Thank you so much for joining us today.
Hi, good morning. Thanks so much, Alexis, for that nice introduction. So today I'm going to be talking about something unique. I'm Deanna Kelly. I'm trained in psychopharmacology. I've spent of my training years learning about medications and how medications work in the brain and board certified in that area. But I became involved with science. And along the way, we were looking at why people with schizophrenia have inflammation in their body and in their brain. And we stumbled across the idea that gluten causes antibodies and an immune response. So if you would have asked me a decade ago, or even more, since I've been working on this for about a decade, if I would ever be considering the idea of gluten, relationship to severe mental illness, I would have said no. I would never have imagined that. But science took me there, and as I tell you the story today, I'm going to put it couch it in the framework of a story to help you understand what we know and why the data shows us that gluten is involved with a subgroup of people who have schizophrenia. So my disclosures are listed here. I've served on an advisory board for a few programs, a consultant to Medscape, but none of what we're talking about today is related to any of these relationships. There is educational need practice gap information listed here. As Alexis said, there are currently treatments for schizophrenia remain inadequate. We're trying to move towards precision medicine, or the idea that each person should receive the best individualized care. We're not there yet, but we are trying to move into that direction. But better identification of treatment targets and better understanding individual patients and what their relationship is to some of the things I'll be talking about today: inflammation, immune response, and gluten. Learning objectives are listed here. I'm going to be talking about the role of inflammation. I'm going to characterize this subgroup of people that I'm speaking of. And then we're going to recognize the potential mechanisms related to this, why this is happening in this subgroup of people, and then what might be treatment options. So that's what I'm going to go over today in telling the story. So I'll start off by letting everyone know if you don't already, that schizophrenia is linked to inflammation. So an inflammatory response in both the body and the brain. And I'll tell you a little bit more about that. There's the bullet points here tell us about the different evidence to suggest that inflammation occurs. This happens from infections the mothers could have early on. We find data in looking at genetic studies where the genetic immune markers are linked to the same areas that schizophrenia susceptibility might be linked at. We have large epidemiologic or large data sets that show us that autoimmune diseases are put people at risk of schizophrenia and run higher in families of people who have schizophrenia. And then markers themselves found in the body called cytokines or chemokines, other markers found in the brain and the body are disrupted often in people with schizophrenia and even before drug treatment. So there's this inflammatory response that happens, but this doesn't happen in everybody. And not everybody with schizophrenia has a very similar presentation. The diagnosis itself includes people who have robust hallucinations and delusions, but also those who have primary negative symptoms of the illness or more disorganization. So a lot of the people that we work with, our clients, our patients, don't look very different. So in fact, this inflammatory story that a subgroup of people might have inflammation makes a lot of sense, especially when you look at our leaders in the field like Dr. Will Carpenter, for example, who founded the Maryland Psychiatric Research Center, that suggests that it's possible that schizophrenia is a clinical syndrome rather than a single disease. Then there might be different subgroups within there, and we might eventually in the future have different diagnostic categories based on people's genetics or environmental impact or biomarkers, for example. But I'm suggesting that there's a subgroup of people who have schizophrenia who have a high immune and inflammatory state, and this could be a group of people that we might treat differently or understand the illness in differently. And this is just another idea showing you visually how to deconstruct the illness, thinking about we have everybody who falls under this diagnosis, but then different genetic, environmental, and biologic substrates could separate our groups so that we could treat these groups in the future, hopefully with different treatment regimens as opposed to the same sort of structure as we go through evidence-based care. So the story today starts with wheat and schizophrenia. I'm going to take you back a little bit. So during World War II, so this is a long time ago, this gentleman named Francis Dohan, Dr. Dohan, was the first in the field to really identify this concept and bring it to the forefront. And over the years, the idea has waxed and waned, and science is now exploding in the area. But during the World War II, for example, as wheat consumption went down in some of our Scandinavian countries, admissions for schizophrenia also went down. So we have this somewhat relationship, but it's not causal. It's just a correlative relationship. But we also know that as wheat consumption, when it started to go up in the United States, admissions for schizophrenia went up. So this is sort of our first papers in the 1950s and 60s to suggest that wheat was playing a role in some of our patients. But other epidemiologic studies went on to give us more insight into that, showing that in some studies that were done, schizophrenia was almost a non-existent diagnosis in populations before Westernization or before wheat was introduced. And then there was an interesting set of studies that were done looking at these rural tribes in the South Pacific, Papua New Guinea, these tribes, one of the tribe is Yap, and the tribes in Malaysia were looked at in the 50s and then the 80s, before and after we introduced wheat. And they looked at how many people had a diagnosis of schizophrenia within these countries. And we're looking at several thousand patients here. But what they found is that before Westernization, there was virtually no schizophrenia diagnosis or psychotic symptoms as we know it today, and other domains of the illness. But in the 80s, after Westernization, we find that schizophrenia occurs similar to other places in the world. So it's accumulating evidence. So then following this, in the 60s, 70s, and 80s, there were a variety of small studies that were done to remove gluten, thinking that gluten played a role. So we removed it from the diet in certain inpatient settings and other studies. Some of them are well done, some of them are small, some of them are not so well done because this is early on in our clinical trial understanding. And the green text suggests that there were improvements in symptoms, and the red text in the more recent 80s studies suggested that there was no change in improvement in symptoms. So there was sort of a mixed bag of data on some people getting better and others not. But at this point, we really had no biomarkers to guide us. We really had no understanding on who should be treated with the potential removal of gluten and who was at risk for having wheat related to their illness. It's not everyone, it's only a subgroup. So this is what the data showed us, and it sort of disappeared then for several years after the 80s. And then we come back to it in more recent times, and I'm going to show you the more recent data. But before I go too much further, I want to make sure that you understand why gluten is important to look at. It's you hear about gluten-free diets. Some people have celiac disease. We are not talking about celiac disease today, and I'll tell you a little bit more about that. But we're talking about someone having an immune reaction to the proteins in wheat called gluten or gliadin, the protein. And so gluten is a protein composite. This is found in the wheat food that we eat, like wheat, barley, and rye primarily. It's made up of a few proteins. Gliadin is the one that I'm interested in. This is what gives bread its ability to rise and gives, and some of these give elasticity to the bread, to wheat, for example. But gliadin itself is a densely packed protein. So it has a low surface area. It's very difficult to actually digest. So our bodies initially were not designed to absorb gliadin through the gut. It's passed through the GI tract and excreted. So it's broken, but we do see people have an immune response to it. We have antibodies that are formed, messengers that come, identify it as a foreign substance in the body and create antibodies over time. And so this means that there must be something happening for it to get into the body, like a leaky gut, and I'll come back to that. But potentially most people, we were not built to absorb it. It should pass through the body, and but some people are having a reaction to it. So this gives you an idea of gluten-related disorders. I was talking about celiac on the left-hand side. That's an autoimmune disorder. Your body attacks the villi of the stomach. It causes a lot of gastrointestinal symptoms. But then there are other types of reactions. And there's allergic reactions where you're going to have skin rash, etc. Wheat allergy, but I'm not talking about that today either. I'm talking about non-immune, non-allergic gluten sensitivity, sometimes called non-celiac gluten sensitivity. So antibodies are being formed against the protein, but it's not an autoimmune disorder. So it doesn't have the same gastrointestinal symptoms, and this is where the brain comes in. So just to show you a little bit more about celiac disease and gluten sensitivity, I'm separating them here, but there's some interesting overlap, and they're both triggered by gluten. They're both underdiagnosed, and the treatment is removing the antigen itself or gluten from the diet. But it's much more common to have gluten sensitivity, and there are some GI side effects, but often not the presenting side effects. We'll often see in patients who have this joint pain, some skin disorders. We'll see fogginess, headaches, and some neurologic and psychiatric symptoms. And this is what led us to understanding this immune reaction. I listed here how you diagnose celiac disease, which I'm not going over today, but it's separate. It's different antibodies. It's a different process. We are looking at antibodies to gluten, the lower part of the screen. There's no standard or no consensus on what is the biomarker for this because it's very non-specific when we look at these antibodies, but it does tell us that the body's having an immune reaction when we see these antibodies or something is getting through to the gut. So we're looking at these antibodies. What's interesting is that, I'll go ahead and skip to the next slide. What's interesting is that these anti-gliadin antibodies, so these are just antibodies against gliadin. So I'll refer to them as AGA or gliadin antibodies. But this is a study that we had done on the left-hand side where we looked at the prevalence. How many people have these antibodies in their blood if we would draw their blood? And in the general population, we see about 10% of people have them. So that it does happen in the general population. But in people with schizophrenia, we see about a third of patients have these antibodies. So that's significantly different and higher than the general population. And on the right-hand side, this is just showing it's been replicated, and meaning it's been shown again and again. And this is only one other study outside of us, but we've replicated and we've shown these same results about a third of people in 3 studies now. So it's pretty well established that a third of people, this subgroup, will have high antibodies. Now, what does that mean? How does that differentiate people? And that's where my story sort of kicks in. I was also showing you, this is some additional data from Faith Dickerson and colleagues at Shepherd Pratt, et cetera, but they also find higher antibody levels. So there's lots of people who have discovered this, have replicated it, and we now know this to be a fact that we see these higher antibodies in schizophrenia. We also can see it on other psychiatric disorders. I'm focusing on schizophrenia today as that's my specialty, but there are the idea that gluten can cause disruptions in the brain besides schizophrenia is also very prevalent in the literature and growing with ideas of autism, anxiety, depression, et cetera. But what does this subgroup look like? And so this subgroup clinically is hard to determine. When we look at large groups of people, we can actually see that in comparison to everyone else, positive symptoms aren't quite as robust. We don't see as robust positive symptoms like hallucinations and delusions. We see other chemicals like kynurenine, which is it's linked to schizophrenia potentially in some of the work we do at the research center. But looking at someone, you can't tell that this might be someone who might have a different underlying cause for their disorder or relationship to wheat by looking at people. So it's really a biomarker and a blood level that we do see differently. But what we first set out to look at is back to the story that inflammation is high. I suggested and thought that maybe those who have high inflammation are those who are having an immune response. It makes sense. So what we did is we looked at markers in the blood and the brain of those people with and without these high antibodies. And lo and behold, we find a relationship. And these graphs just show us the relationship of the antibodies in their body, in the blood, to immune markers. And specifically here, they're TNF alpha and IL-1 beta, but these are just cytokines that are in the body that signify inflammation is happening. So the higher the inflammation, the higher these antibodies. So there's a linkage of these two, one causing the other, possibly the inflammation or the immune response leading to inflammation in the body. Inflammation generally is not a great thing. We do need inflammation for some processes and to fight infection, et cetera. But generally speaking, long-term inflammation is not good. We also, and this is showing us just about the brain study, but we also looked at neurochemicals in the brain that are related to inflammation. See, these inflammatory markers are seen high in MS and other diseases in the brain, neurologic diseases in the brain that show inflammation. And we also see the higher the antibodies, the higher the level of brain inflammation. You can imagine having inflammation in the brain when we're not supposed to have inflammation in the brain could lead to disruptive processes or symptoms or worsening of symptoms. And that's where the connection we've been looking at. So a summary of that characterization, to make sure you understand what I'm talking about, is we find a third of people have these antibodies who have schizophrenia. We don't have a clinical diagnosis. We can't look at them and diagnose them clinically that having gluten related, but we do know that they have higher inflammation in the body and higher inflammation in the brain. So wouldn't it make sense to develop strategies for treatment for these people instead of having everyone treated the same way? If gluten or if inflammation plays a role, it would make sense to try to treat the immune response and the inflammation to get that under control first, as that might be causing worsening or related to the schizophrenia symptoms. And that's why the diet and the removal of gluten is some of the work that I've done. The science took me in this direction. And just this is an older paper that's published in 1997, but it first gave me hope and understanding. If we removed gluten, could we change the brain? And in fact, this is a case report of a 33-year-old man with schizophrenia. Now, this is a celiac case. This person had celiac disease, but it was an early case that showed us on brain scanning. This is using SPECT, But if we looked at blood flow in the brain, we actually find that before and after a gluten-free diet, blood flow, particularly in some areas of the brain that are important, this is cerebral, like the front of the brain, changed. And these are just the pictures before and after, and it improved, blood flow improved in the direction we would think to be normalized after a gluten-free diet. So it gave me hope that we could actually change psychiatric symptoms. The brain could actually be changed, flow, like the function of the brain could actually be changed if we removed inflammation and immune response happening. So this is, well, there's also other case reports. I put several here. There's been now, I think, 10 or 11 case reports in the literature of psychiatric symptoms improving when gluten was removed. And these are not celiac patients. They do not have celiac disease. And many times it took a long time for someone to be able to test for them and to look at this. But just so you know that there are many cases in the literature that also support this work. So we decided to first start with a study in the inpatient setting where I'm located on the grounds of Spring Grove Hospital to look and see if we had someone in the hospital who have these antibodies, monitor them for a couple of weeks. We did a 2-week period and looked at their symptoms before and after by standard rating scales. We also looked at their neurologic symptoms because there's evidence that gluten causes neurologic symptoms like gluten ataxia, seizures, et cetera, which is also well established in the literature. So we brought in 2 people to stay in the inpatient setting. We wanted to control their diet. We wanted to make sure that there was no gluten introduced during this time we were looking at their symptoms. And these 2 people had improvements in their symptoms. In fact, patient 1 is in blue with robust changes in, these are some rating scales to look at symptoms. But the second bar in the middle there, right here, that is the negative schedule for negative symptoms. And negative symptoms dramatically improved in this patient. But we saw improvements in neurologic symptoms as well as the positive symptoms of the illness as well. So then we were funded by our National Institutes of Mental Health with this amount of data coming in. We now knew that we had a subgroup of people that was clearly established. We knew that our pilot data showed us that we could actually improve symptoms if we removed this in a subgroup of people. And remember, this is different than the old studies where they brought in anybody with schizophrenia and some people got better and some didn't. We would never expect everyone to get better. That would never be the case because 2/3 of our patients with schizophrenia don't have antibodies. They're not having immune response, but 1/3 are. And so identifying those people would help us to maybe think about treatment a little bit different. And so then we performed a randomized double blind. This is a gold standard way to do a clinical trial. What we did is we gave everybody on the inpatient unit a gluten-free diet. So everybody had the same food, but then half of the people, kind of like the flip of a coin, received gluten flour in a shake and half received rice flour in a shake daily. We don't know who got what. They don't know who got what. And we analyze it at the end to see introducing gluten and no gluten, how that differs. This is our what's called inclusion and exclusion criteria. People had to come in between 18 and 64. They have to, of course, sign informed consent, be interested in participating, but we did not allow people with celiac disease in so that did not confound our findings. And this is what it looked like in this diagram. We actually, in this small randomized study, we had 19 people receive either one of the treatments, gluten-containing diet or gluten-free. And then we had 7 people at the bottom here complete of the 16 that started. And so this is a table just showing information about the 2 groups. And overall, they were very similar as they were randomized to different groups. So that just tells us they have a mean age that's somewhat similar. It's not significantly different, but we do have small groups here. This is what the negative symptoms look like in this small study. So this is a change from baseline in negative symptom scales. And you can see the orange line is the gluten-free diet group with negative symptoms changing by about 10 points on the scale. And remaining that way after, even in the initial early weeks. The blue line is really a kind of a no change in symptoms, not significantly different, goes up a little bit and a little bit variability. But what we call effect sizes are are moderate. This is clinically significant change we see in negative symptoms in this small study. And in fact, those people who had a robust response, a greater than, I think, 30% response, was about 60% of our patients, and versus only one person in the placebo in the gluten-containing group. So there's evidence to see that, well, some people are doing very well, some people are doing a little bit better, but people having gluten are not doing better. We also looked at cognitive function, like looking at attention and working memory. And sometimes these symptoms are important for functional outcomes, for having interactions, going to school, being able to hold a job. These are important on the functional side for people, and even sometimes more so than having hallucinations not completely under control. So what we do see is that in the bars going up means an improvement relative to the gluten-containing diet, so that almost all the areas and domains of cognitive functioning as listed are improved. In particular, attention, the ability to have an attention span was robustly improved here. You can see. So these are moderate to robust effect sizes in the study. We also saw inflammatory markers and kynurenic acid, which I've talked about just briefly, also improve. So these show the blue is the gluten-containing, the red is the gluten-free. They're all going down, which means improvement overall. So we're seeing improvement in inflammation, just like we would thought, and that's a good thing. So in this group, by taking away the immune reaction, by improving, this is a 5-week study, by improving that, we can improve some of their psychiatric symptoms and their inflammatory markers. This also shows us that we do see decrease in antibodies, and not a complete decrease. We do see a 34% decrease. We were hoping to see more than that. So in our follow-up studies, this data helped us. We now have a large replication study happening at the research center, a double-blind randomized controlled study of gluten-free diet versus gluten-containing in this group. And we're giving more gluten into the diet so we can actually see possibly a significant decrease relative to the gluten-containing diet. We weren't sure we had enough gluten in there to show a difference. Even despite improvements, we wanted to make sure we maximized our study. We also did, despite not thinking we had a lot of GI side effects, we saw robust improvements in most GI symptoms from across the board, reflux, indigestion. So people taking gluten from the diet, even though it's not the main concern with non-celiac gluten sensitivity, we see our patients improve in these domains really robustly, especially in the total symptoms. An effect size of 0.8 is highly significant. So then I mentioned we're doing a confirmatory double-blind study, which means we're doing a repeat of what we did with a larger sample, and to show that if this, to be able to prove if this works or not. We have the ability, working in the state kindly with our state system and at the University of Maryland, the connection we have on our treatment research unit, which we've had for over 30 years over at Maryland Psychiatric Research Center. We have the ability to run inpatient studies, and a lot of people around the country do not. So the NIH knew that we were one of the only sites who could do something like this with a full control of diet. And so we were able to get funding to move on and do the similar study in a larger population. And that is ongoing now. And we are currently recruiting for that study. And I'll mention it in a minute. But before I wrap up with the end of the story, I think it's important to maybe think about why this is happening. Because understanding why we have a third of our patients with this inflammation and immune response might also lead to treatment targets in this population. Well, there's the idea that the gut and the brain, the blood-brain barrier, might be leaky. And you've heard of leaky gut potentially in the literature or read papers about it. But the tight junction, the tight junctions for these cells in the gut and in the brain can be modulated and open up and let more things through. And we now know there are tight junction regulators. There are chemicals and proteins in the brain and the body that regulate these tight junctions that might open it or close it, and when it shouldn't be. And we know that certain things in our diets can change how permeable the gut barrier potentially is. And the gut and the brain have some similar characteristics for the permeability. They're not supposed to be letting things in and out very easy. They protect. And so this is data from Hopkins on the right-hand side. And what it shows us is they looked at cerebral spinal fluid. So they did spinal taps, which we have never done, but they did spinal taps looking at the antibodies after they crossed the blood-brain barrier into the brain and nervous system. And they find that if you're a healthy control, there's no relationship to what we see floating in the brain is what we see floating in the bloodstream. But in schizophrenia, there's a relationship. And this blue line going up tells us that sort of equally balanced between what we see in the brain, the body we see in the brain, suggesting that these antibodies that we see in the blood are crossing into the brain somehow. And so this is Emily Severance and Bob Yolkin's work at Johns Hopkins, who do some lovely work, but they show us that this relationship is in fact happening. And so it's interesting then, because now we have evidence that these antibodies that we're interested in that are causing these problems potentially are getting across the blood-brain barrier. So the leaky gut might be a target in the future. We might be able to prevent the gut from being leaky, and that could prevent all these downstream effects that we're seeing for things that shouldn't get in. And in fact, we know that there's a tight junction regulator called zonulin, was discovered here at the University of Maryland about 15 years ago by Alessio Fasano, who now directs the Harvard Celiac Center. We've worked with him for years, but he actually showed that zonulin can regulate tight junction proteins. And in zonulin inhibitor, something that blocks the release of this protein, is in clinical trials currently for celiac disease and some rare disorders where there is some there are things crossing the the gut barrier. So there's potentially evidence that zonulin inhibitors in trials, and we've been trying to get one of these to study, but this could be a target potentially, or something like this for treatment. So there's ways, if we don't remove gluten from the gut, we could actually probably stop the gut from being so leaky and an immune reaction happening in our patients that this shouldn't be happening in. And this just shows us that zonulin, the other autoimmune disorders also have high zonulin because their gut is leaky. So celiac disease, but type 1 diabetes, et cetera, also and MS are associated with high zonulin levels. So zonulin is leaky guts happen in different diseases as well. We actually looked at zonulin levels and found that mean levels in schizophrenia patients were over 2, which is generally the cutoff for normalcy in the sample we had. But we also see that different genotypes of the prehaptoglobins, a genotype might be related to how much zonulin you have. So genotype might be related to gut permeability. More to come on that, but it gives you an idea of how we're trying to understand the subgroup and understand treatment targets so that we can better treat individuals. Also, the gut microbiome, the bacteria in the gut, might actually lead to changes in psychiatric symptoms. And we now know from work out of Ireland that animals, mice and rats born in germ-free facilities without the normal flora from their mothers, have brain development that's not completely normal, more anxiety states. So we do know that the gut bacteria in our bodies over time, evolution, has allowed us to, the neurotransmitters, et cetera, has allowed us to develop organs in a more, that they play a role in normal organ development. So that there's lots to come in the area of what's happening in the gut. There's more genetic makeup there, and these bacteria have been living with us symbiotically for a long time now. But actually bacteria is possibly related to this gluten story. So that maybe bacteria modulate how gluten is degraded in the gut. We also know that tryptophan, some of these amino acids in the body, they're important and related to to kynurenolic acid I've mentioned, et cetera, are modified or broken down by bacteria in the gut. So certain bacteria could change how the brain eventually works. And so that's just more to come, but we have some evidence to show, and there's a lot to describe here, but really the take-home point is that we did see in our small study that I was talking about, those who are on gluten and those who are not have different gut bacteria. So over the 5 week of the study, we could change the relative distribution of bacteria in the gut based on diet. I know this is, interesting to me. It blows my mind as well as many others. So there's exploding work happening on the idea of how bacteria regulates the brain and mental health. Before I finish up, there's one other possibility. So I'm throwing out possibilities to you so you understand just that how much work is happening. But there's also the idea that some of the receptors in our brain, like what we call the NMDA receptor, it controls the excitability in the brain, might have a component that actually matches gluten itself. There's a paper that came out that showed that the structure, if you break down the structure, the DNA of gliadin and the structure of this subunit of the receptor, they match a lot. So what if gluten gets into the body and shouldn't, and then the body sees it as a mimicry? Body wants to attack its own self because it thinks it's the foreign substance. So it's a possibility that we might, if we could stop that leaky gut and stop things from getting in, we might actually stop some of our own potential damage that might happen from our body attacking its own receptors or own components. So that's a possibility, but very little data out there to date. So this is just finishing up. This is suggesting that a gluten-free diet for this subgroup could be important, but there's also other ways to get at this, blocking inflammation, blocking gut permeability, etc. So there's hope that we can develop things in the future to help us in this subgroup of people. So I'm giving some ideas of that. Keep in mind that you can get tested for native gliadin, which we test for. A lot of times people think that it's for celiac disease or some other related antibodies. It's often confused, and often the wrong tests are ordered if regular clinicians are doing this. So I put the test code for LabCorp specifically so that you could get native gliadin and understand if there's a gluten-free or gluten reaction happening. But and I also put information about gluten-containing foods, because people who should be on gluten-free diets, it's not covered by insurance. It is more expensive, but we on the treatment team teach everybody how to do cooking. We teach them how to shop for gluten-free foods. We give cookbooks, and we hopefully teach people to try to maintain a gluten-free diet if their symptoms are getting better. And we have had people get better in this subgroup of people. We do have the ability to be tested at our research center. It's a simple one-time visit. We actually will pay for your transportation as well. So it's a benefit between the ages of 18 and 64. You do not have to have a psychiatric diagnosis. So this is anyone in this age group. You come over to the Spring Grove Hospital grounds and do our research center. Takes about 30 to 60 minutes. You have to, the patient or yourself or whoever's being tested would go through the informed consent process, make sure you understand the risks and benefits of the blood draw. And then you have an optional stool sample because we're looking at the bacteria. So you also get compensated for the blood work that you get taken, the tubes of blood that are taken. Your data becomes the blood itself, when we start to analyze it, is anonymous to outside sites when we send it. But we are looking at large populations to better understand how prevalent this is and what it's related to, especially with the stool samples and the bacteria. Like, what are these antibodies doing and what are they related to? And if you're interested in participating, or you want to refer people, you want to refer patients, families, anyone, we have a phone number, and we also have a email address, so people could reach out to us. We have found now about 7 people who have celiac disease who didn't know it, which was very important and to improve care, and that those are important. But we've tested over 500 people now. Celiac disease is not that common, but we continue to see about a third of people with schizophrenia, and about 10% of our healthy controls have these antibodies. In summary of the entire talk, I gave you a lot of information, but I hopefully told you a story that helps to understand how research is improving precision medicine. To summarize, antibodies to gliadin are present in about a third of people with schizophrenia. They are not related to celiac disease. This subgroup we refer to as gluten sensitive, but it's not a standard terminology in the field yet. But removing gliadin may improve some symptoms in schizophrenia. We've seen more negative symptom improvement, but case reports and some of our early work shows some positive symptom improvement as well. But gut permeability, the microbes in the gut might play a role in why this happens. And to know that we have a large study underway, but we also have a study to get tested for gluten as well. But this gives us hope that novel treatment targets and this kind of approach in general, this approach by looking at biomarkers and subgroups of people is a very important way to move science forward so that we're not trying to treat everyone with the same antipsychotic. As of right now, our clinical trials with our pharmaceutical companies are testing a treatment, but they bring in anyone who has a diagnosis of schizophrenia. And sometimes people get better and sometimes they don't. And sometimes the drugs don't make it to market. But maybe it's because they don't have the right group of people who would be beneficial for that type of mechanism. And we have new mechanisms coming out with antipsychotics. That just gives you a sense. I always like a quote by Ellen Sachs. My good fortune is not that I've recovered from mental illness. I have nor will I ever. My good fortune lies in having found my life. And I always sort of end with this when I give this talk, is that as researchers and clinicians, we're on a journey to help each person, not the group of people in science, to find their best lives, but everyone deserves optimized and personalized treatment. So if you are a loved one or someone who has some immune response to gluten, there might be help to try to remove that, or it might be important to try to maximize decreasing that immune response because you could have some improvements. So overall, I just want to thank my team. We have a large team. We work with Johns Hopkins University, Harvard. We've had many people, and my team is picked older pictures listed there prior to COVID. But we've been funded by NIH, the Brain and Behavioral Research Foundation. There's a YouTube video related to some of my work around this. I had won the Maltz Prize for Innovative and Promising Schizophrenia Research related to the work with gluten in 2017, and the YouTube video was fun to make. But that's all I have for today, and I will stop sharing my screen.
Thank you so much, Deanna, for such a great presentation. We would now like to open up the workshop for questions. If you have any questions, please post them in the Q&A to the right-hand side of your screen. All right. So, Deanna, what specific populations at higher risk of this disorder? Does it start at a specific age?
Yeah, so that's a really great question. We have not done the work yet in adolescence to look at see if these antibodies are happening early on and this immune response is happening early on. However, Faith Dickerson over at Shepherd Pratt shows that in people in what we call first episode, or in their very first or in treatment naive patients before they've ever received their first antipsychotic. So these are late adolescence, early adulthood people. We still see these antibodies to be high. And in fact, she shows that the younger you are, the higher the antibodies. So this immune response might actually be happening more robustly when they're young. So if we could prevent it early on, and I don't have the data to suggest this, so I'm not suggesting it, but it's a possibility of thinking, if we looked at this research, that potentially if we stop this immune reaction earlier, it might lead to attenuation of psychotic symptoms. I mean, what if we didn't have schizophrenia happen if we could identify immune reactions early? I don't have that data. I mean, I don't want to sell that story, but those are things we have to look at. In terms of the people that are at risk, traditionally, this is a hard question to answer because it's not standard of care to draw this on everybody, although I would love to. However, the people that often come to us are those who have family members with autoimmune diseases in their family. Other types of autoimmune diseases like type 1 diabetes, maybe some celiac, a lot of GI side effects in their family, lots of joint pain in their family. Often these people will come because there's some suspicion from their physician or their family member that there might be worsening of symptoms when they have gluten, or there might have been a viral infection or something, inflammation that might have led to leaky gut, and so that it happened on a quick onset after viral infection. There's a variety of ways people have come to us and have found these antibodies, but traditionally it's more those people who have had some GI, some family members with autoimmune or histories of other GI that we often end up seeing first when we test for them. We do have some patients we are in contact with around the state. They might be on here today, but we have people that actually who are very well between periods of gluten and very sick when they're on gluten. And hospitalizations are challenging because hospitals give gluten. It makes it worse. It's not very common, but there are cases of this happening.
Right.
Yeah.
Okay. Thank you. Next question. If you have you connected with the Ehlers-Danlos syndrome community who has deficiencies in connective tissue proteins? Are you familiar with that?
Yeah, I am actually. And when I did some training for my champion grant, my project ECHO, where we teach physicians around the state, it's a separate study. We actually went to training and we met the group that were training internationally for the Ehlers-Danlos syndrome international ECHO program. It's a rare disorder. It's a connective tissue disorder. Often people have scoliosis early on, difficulties with their back, and I'm not familiar with the entire syndrome, but they have a lot of connective tissue sort of issues. I have not looked at connective tissue proteins. We have only looked at tight junction proteins and like the claudins, we've looked at postmortem studies too and found that the blood-brain barrier is, I didn't show that data, but the blood-brain barrier is disrupted in schizophrenia and in autism too. But that's different than connective tissue proteins. Good question though.
Great. Another question. How does ethnicity play a role in the high antibodies?
So we've looked at different populations. We have not seen a higher rate of antibodies in any population to date, whether that was age, whether that was race, whether that was ethnicity, or gender. We have not seen differences. But now that we have a population of over 500 people tested, which is larger than any population ever, we're going to start to be able to look at, and I think it's more of a genetic issue. And so I've done some other work with ethnicity and some different genetic disorder that's higher in different, the genetics are higher in different ethnic groups. And so this would be interesting to continually look at. But right now we see no specific group of people that stand out for being at risk. Yeah.
Okay, great. Another question. In reference to this study, does this apply to people with schizoaffective disorder also and other psychiatric diagnosis?
Yeah, I overstate it when I just say schizophrenia. I should say schizophrenia related disorders. So schizophrenia and schizoaffective are included in all of our work. So both groups are included in everything I presented today. So sorry, thanks for that clarification.
Sure. Let's see. What else do we have? Is there a connection with SIBO and the increase in mental health challenges?
So SIBO is an emerging sort of area where there's different bacteria overgrowth in some areas that shouldn't be. And so this is getting at the fact that the microbiome is disrupted. And SIBO is, if you see some holistic physicians, there's people around the Baltimore area who are becoming experts in understanding if you have SIBO or not. There's ways to test for how the bacteria overgrow through breath tests, et cetera. There's so much work to be done. Like just so that the audience is aware, science and clinical care have not traditionally connected the gut and the brain together. We understand the relationships. The vagus nerve goes between the two. You understand when you go to give a talk how nervous you get and your stomach hurts, or you have GI side effects from that. It is so related, but yet there is not a lot of people studying this connection. And so I think this is all to come. I think that we are looking at relative abundance in the gut, whether that is termed SIBO or if it's looking at the different representation, the bacteria that are present. Then hopefully our next study, and by people like you donating stool samples, will understand like what is happening in the gut related to these antibodies. But until we have enough stool samples and to look at these large populations, please come see us and donate for science, anonymous stool samples. But yeah, those are things we're looking at. But this is a smart audience.
Yes, they are. And just a comment there in reference to, I guess, the Ehlers syndrome. There's a link between mental illness and the Ehlers-Danlos syndrome. And one audience member said that their daughter, has psychosis and EDS as well.
Yeah, no, these are really, really interesting because these are involving things like mast cells and possibly like B cell and T cell activations. It's different. And we're starting to look at B cells. We've added to our protocol one more tube of blood to be able to pull B cells, for example, to look at some of the upstream effects of the cytokines to see maybe where in the immune reaction this is happening. But it'd be very interesting for people who have some of these autoimmune or these different connective tissue disorders, et cetera, to be tested for these antibodies to see if it actually, and like I said, it's a free testing that we do, and $25 gift card or $25 fee, the compensation that you also get. But it would be interesting because we don't have any connection yet. I don't know of any people that have had Ehlers-Danlos like come to us yet. So that would be very fascinating, and you get your results back, and so does your doctor if you want them to have it.
Okay, good. Another question just came through. Can you briefly explain the difference between paranoid schizophrenia and schizophrenia? And are men with guts more prone to gluten-related deficiencies than those who don't have large guts?
Yeah, no, these are all good questions, especially when I go through a new topic that has lots of information. So, and sometimes it takes me a while to kind of understand what all of this means. But when we talk about schizophrenia, it's really a group of symptoms that fall under a categorization of having hallucinations, a mixture of hallucinations, delusions, or paranoid thinking in there as well. Paranoid schizophrenia really is a characterization that just notes that the symptoms are primarily more paranoid in nature because it separates, broadly speaking, it separates us in understanding people that we see with schizophrenia who might not have paranoia or might not have those positive symptoms really robust, like hallucinations, delusions, and might have more disorganized thinking, having trouble thinking clearly, have more withdrawn and lack of pleasure with things. So I mentioned in the talk how wide the symptoms are. So not everybody that we see or work with looks the same. But paranoid schizophrenia really just is a designation that more paranoia is present. And also around the idea with the guts. We don't know why different people's guts might lead to gluten sensitivity right now. What I suggested is that, I don't know if there's differences in men or if there's differences in women, but we understand that something might be happening at the level of the gut and the absorption that might be leading to some mental health issues. And that's the idea and the story I was bringing today. But I don't know the size of the gut or anything that relates yet. That's all we have to learn.
Right. Thank you for that.
Yeah.
Another question that came through, Deanna. If a person participates in a blood draw, do they receive an interpretation of their results?
Yeah. So what we do is if everything's normal, we tell everybody you won't hear from us unless you want to, but you'll receive your results back if they're positive, and we give you a sheet. We can go over that. We'll tell you why they're high, what that means, and how you talk to your physician about it. If you come back as a celiac patient, we will suggest very strongly it's standard of care to be on a gluten-free diet if you have celiac disease. It's clear it's a bad autoimmune reaction, and we would talk to you about getting a release of information to talk to your doctor if you wanted us to as well. So we would go over but at any point, even if you don't have any issues at all, we still certainly, if you called us, we would go over the results with you. So that's the beauty of this is you get your results back, and then they're aggregated for research as well.
Great. And as we're winding down for the last 5 minutes, one person just wanted to know, was it possible to restate where individuals who are interested in participating anonymously in the stool sampling? So could it be anonymous that they could participate? And
so what happens is you have to, for research, you still have to come in and do informed consent and fill that out. Once you do informed consent, your blood draw is taken. And that means that you understand the risks and benefits of the blood draw. We keep everything, all information in, as guidelines and federal regulations state, like locked doors, locked cabinets, password protected computers, etc. But once we get your information, once we work with Johns Hopkins to look at the antibodies. They don't have your information on the tubes. Everything becomes de-identified at that point, and then we get the results back. It's de-identified information that comes back. You're not anonymous completely in the fact that we could know who you are because you had to sign informed consent, but we would not be relating your information to anyone again. How to participate? You can call the number 443-571-0086. We also have an email address. I had showed that earlier, but are the slides, Alexis, are the slides available to people?
Yes, so the slides will be up on our NAMI Maryland website. So if persons will be able to access this at our NAMI Maryland website within maybe about 2 weeks. Everything will
on
be
slide 48 on my slide deck is the information how to participate. But anybody could Google me and reach out to me. There's also we have the Maryland Psychiatric Research Center has a website with information. You can go there. You could call, but you could reach out to NAMI, and I'm well connected to the NAMI community, so they can refer you over to you. So please don't feel like you can't find us. We would be able to connect with you easily.
Great. And Deanna, just give me that number again, and I'm just going to put it in the chat real quick.
Yes, 443-571-0086.
086. Great.
Yeah, and also I'm going to see if I can, yeah. Well, I was hoping I could paste the email address too, but it's not pasting for me. But you can reach out by the phone number for sure.
Great. And let me see. Yeah, that you did answer the question about the slides. We will be available in about 2 weeks in the NAMI Maryland's website. That was wonderful. That was a wonderful presentation. Thank you so much for that well-informed information.
Yeah, thanks for having me. I really enjoyed giving the presentation. So thank you.
So this is all the time that we have for now. So thank you all so much for joining us.